Ladies and gentlemen, organizers, thank you for the invitation. At first, it may strike you as unusual, a surgeon who's talking about when not to operate. But actually, this question has been on the surgeon's mind as long as there are surgeons. So the only thing that is a little unusual is that we have just gained so much, we've done so much effort in the last 20 years to obtain a better survival and a better local recurrence rate by improving surgery, by adding radiotherapy. And we may have forgotten a little bit about the function, and now we're trying to get the balance right again. So the hard thing is to get a better function without losing what we've gained in the last 20 years. So, and in this concept of organ preservation, it's not so much technical developments that are driving this as much as a change in the mind of surgeons and clinicians. So our concepts, our ideas are changing. So we are now willing to let function be a part of the decision process. And what we are getting used to is what, of course, medical oncologists, if you treat a patient for 4 or 6 months, you have the time to adapt your treatment to what you see happening. A surgeon, an operation takes a couple of hours, so you make your plan and you stick to it. And now that we're moving the radiotherapy and the chemotherapy up front, we have a lot of time to change our plan, and that is something we have to get used to. The other thing is that our relationship with radiotherapy in rectal cancer was not complementary. We were actually targeting the same thing. So why would you want to kill a tumor twice? Why irradiate the primary tumor and then we take it out? Now we rather think of it as two complementary strategies. When radiotherapy is very good, maybe we can decrease the surgery. If the surgery is very good, maybe we can omit the radiotherapy. And in some patients, we need both. And the other thing is that we are learning, and that's been addressed earlier, there's no rush. If you see a good response, take your time. And that's been illustrated by the deferral of surgery. In anal cancer, we do that. Why don't we do that in rectal cancer? So there's two basic questions. So, of course, when not to operate, that is when there's no tumor left. So how do we do that? So these are the ways to identify complete responders. And there's the additional question, when should you assess this? Not too early. I'll come back to that. And the other related question is, what if we are wrong and there's still tumor left? How bad is that? How early can we detect it? That is related to our follow-up. And can we salvage the patient? Again, in anal cancer, that's customary. So what happens if we detect it too late? If you have a local regrowth that is unresectable, that is bad. If it requires more extensive surgery, that is bad. If it causes metastatic disease, that is bad. But if you do your surgery 3 months later, 6 months later, is this a problem or not? So this is questions for surgeons. Now, not to operate started, for me at least, and for the majority of the world, in 2004 with Angelita Haber-Gama. And this paper shook the surgical world. The results were extremely good. A very good update in 2014. And again, a very high percentage of complete responders. She had relatively high percentage of local recurrences. We have fewer. The majority within the first year. The majority were easily salvageable. And in the first paper it was not there, but in the update, a couple of patients may have been harmed by this approach. You can estimate it 2 to 3%. But then again, that is the mortality of your major procedure. Our experience started also in 2004 with a patient who refused his APR after he obtained a clinical complete response. So we accepted to follow him, and he's remained well ever since. And since that time, we have changed our current protocol that said if you have a local advanced tumor, you're predestined to have your operation. We change that. We add after 10 weeks an assessment. If it looks like a complete response, we wait. If it's a near complete response, you can do a local excision or wait even longer. Selection is mainly by digital rectal examination, endoscopy, and MRI. In MRI, you use the standard images, TRG. We add diffusion, and you can add some tools for lymph node assessment, but these are the minor things. And most importantly, you share with the patient the uncertainty that you're not sure that everything is gone, the risks and the benefits, and if the patient is willing to accept this, then he can enter the program. You tell the patient that there's a risk for a local regrowth and that we need to do careful follow-up. The first year we do 3 monthly MRI and endoscopy, and thereafter 6 monthly. These are our patients. We now have more than 130 patients. The first ones were for our own catchment area, and now we get referred more patients. We estimate this only 15% of the chemoradiotherapy patients because these are fairly advanced tumors. Over 100 patients we just waited. We had 12 local recurrences, so sort of 10%. 3 patients with metastasis, very high survival. 15 local excisions, complete responders did very well. The ones with residual tumor, it were the YPT2 tumors who got local recurrences. So the survival is very good. This is not because we didn't operate, this is just a biological selection of favorable group of patients. So the local regrowths, most of them were luminal, endoluminal. A couple of them were nodal. This is an endoluminal regrowth. This is a lymph node that got smaller and it was still there, so we could have known it had not disappeared completely, but we accepted this and it started growing again. The majority of the recurrences in the first year and a couple of them in the second year, so this is why we do the surveillance most intensively the first year, and we rely heavily on endoscopy because most of the recurrences are endoluminal. In our patients, we could do salvage surgery in all of them, and we had no evidence that there were any metastases originating from the regrowth. Now, what did we learn during this 10-year plus period? We started waiting longer. We now wait 10 to 12 weeks for the reassessment. Whereas initially we relied more heavily on MRI, we now rely primarily on digital rectal examination and on endoscopy. These are typical responders, and we add MRI, the standard, the TRG assessment. We add diffusion. That's for research purposes, but it seems to help a little bit. And we look at the lymph nodes. If they disappear, that's easy. Sometimes you use contrast agents. The other thing we did was initially we didn't want to miss any residual tumors, so we were very strict in our criteria, but then you miss a lot of complete responders. Now we have become a little more relaxed, and we also accept near responders, and you accept that your diagnostic tools are not perfect, and we've added one more diagnostic tool, that is the test of time. Why don't you wait a little longer, and then it gets clear. So if you have a near complete response, you wait. The top one becomes a complete response, and the lower one is not, so you take the lower one to surgery. The role of biopsy and TEM, we have seen, of course, negative biopsies. We've also seen positive biopsies if you biopsy too early. So that is, we don't rely too much on biopsies unless you see a clear regrowth. TEM is a whole other subject. In smaller tumors, I think TEM surgery could increase the number of organ preservation. But in these big tumors, if you have a residual lesion, I'm not sure TEM is going to be very helpful. And we have noticed a high patient interest for organ preservation. And one of our patients has written a book and is sort of our advocate for this non-proven, non-standard treatment. So I would say that organ preservation is feasible, but it's not yet standard practice. If you take the intermediate or advanced tumors, where we already have decided that we're going to give upfront a neoadjuvant therapy, you see a response in 50 to 20%, but it's worth looking for the response. The biggest group of patients that could benefit from this are the smaller tumors, and there's a lot of trials that have been performed in this and a lot of trials going on. They respond maybe up to 50% complete responders. So there's a lot of trials going on there. With good selection and follow-up, you can expect local regrowth in 10 to 15%, and if you detect them early, you can salvage them. And my feeling is that there is little or no influence on survival, but I've put a question mark there because we need to provide evidence on that. There's a high interest of patients, and we have to provide evidence, and for the smaller tumors, randomization is possible. For these patients where you give neoadjuvant therapy already, randomizing is very difficult, and it's already been shown. So what can we do instead of all publishing our 60 or 80 patients? Why don't we join them all together? So this is on the map you can see all the centers who are going to contribute, and I think if we can get all the data together, we have around 1,000 patients who have been treated with organ preservation, and there we might give a better answer on the risk that's involved. So patients who gain the most are patients with distal tumors, because they are facing permanent stoma, the frail and the elderly, and of course patients who respond best, so the smaller tumors, and we would like to see more predictive markers. And then we would like to increase the response rates by increasing radiotherapy doses in the smaller tumors, and maybe by adding systemic treatment for the bigger tumors. And I'm quite sure that organ preservation has a nice future. Thank you.